Hello, my name is Willie Tini Tuniswa, CEO of Open Wound Research and host of the Open Wound Research podcast. Welcome to our next episode where we feature the wonderful, talented, and experienced Jeanine Maguire. Welcome, Jeanine.
Thank you so much. What a lovely, warm welcome. Thank you for saying talented and experienced and not old.
No, as I was saying it, I was like, I mean it in terms of the professionalism and experiences in wound care solely.
Thank you. Happy to be here. Thank you for having me on.
It's our pleasure. It's our pleasure. We've been looking forward to having you on after this long summer. We did speak to a friend of yours, Julie Radovi, in the last episode, and she was fantastic. And post episode, I said that we were trying to get you on next, and she was very excited about that.
Yeah, I was very excited that you had her on. And yes, she's my very good friend and colleague. And it's an honor to get to work with her in various aspects of our life, including PAWSIC, which I'm sure we'll be touching on today.
Absolutely, absolutely. Well, I'll do my obligatory introduction just to kind of stage set here. But for the audience, Janine holds a doctorate from Walden University in Health Education and Promotion. She also holds a Master of Physical Therapy from Newman University, which I believe is just outside Philadelphia in Aston, if I remember correctly.
Yes, you're right.
I'm an old Philadelphia resident, a little bit of inside knowledge there. She's also a certified wound specialist and has been so for a long time. On the professional front, she got started as a director of rehabilitation in the post-acute setting. She then became the VP of clinical operations at Genesis for about 19 years, if I'm not mistaken. For those who do not know, Genesis was the largest at that time nursing home group in the country, with hundreds of nursing homes across multiple states. She currently is the president of PAWSIC, which is the Post Acute Skin and Wound Council. She's also sat on the board for multiple companies in wound care, including but not limited to Direct Supply, Smith and Nephew, Medline, Endurance. And she's won many awards and recognitions, one of which is being elected fellow of the Philadelphia College of Physicians and the Direct Supply Innovations in Healthcare. That's quite a mouthful. You've done quite a fair amount in your wound care life.
Thank you so much. And I don't want to leave out an important starting point for me was actually before long term care. So before skilled nursing, I had never intended on working in post acute care. That was literally a 1 year plan to move to the suburbs, took a job with Genesis, as you said, the director of rehab, and I fell in love with it. I fell in love with post acute care, with nursing homes, with skin integrity and wound management in that space. But I don't want to leave out the beginnings of my career because that was my first real family, my first work family, I should say. And that was St. Agnes. That was South Philadelphia. I was there for 7 years. I started as a PTA, and in that role, one of my jobs was to scrub up and scrub the whirlpools, the hydrotherapy tanks in the day when we did that for wound care after everybody had their treatments. So in St. Agnes, I had the benefit of getting to work in their burn unit, the wound center. Also, was able to follow people after closure, after burns in the outpatient department, and then traditional rehab, where the one common denominator of just about every patient in traditional rehab after CVAs or amputations, they all had skin integrity issues. So, regardless of the setting, skin was always the issue for that population. And so that's really what I brought to the nursing home setting and post acute care was recognizing how important that continuum of care really is.
Oh, that's amazing. How long were you at St. Agnes?
7 years. So 7 years in South Philly and did just rotations in all those different departments. Worked with amazing people, really understood the role of different disciplines in those settings, and really gained a respect for the team approach. So it was really, where I learned that team approach really well.
Oh, that's brilliant. And that segues beautifully into the origin story. I mean, you're already telling the origin story of how you got into wound care, sort of as a PT. A lot of the people that we've interviewed are either physicians or podiatrists, and so it's always been interesting to me to talk to PTs to see how they entered into wound care, because I think a lot of people don't appreciate the role that PTs play.
Yeah, thank you for that. I would say a lot of PTs don't appreciate the role that they can play in wound care. But one line I like to repeat is from Stephanie Wolfel, another PT in wound care, who said it perfectly, and I've carried it and repeated it ever since then. A wound is really just a musculoskeletal injury in which you can see. So everything we've learned in PT school applies to the exercise to increase circulation, to modalities, to promote tissue healing, and so on. And so when you think of it that way, it's often an aha moment for a lot of PTs. But my origin story wasn't wound care. If I went back and told my younger college self this was going to be my career trajectory, I would have never believed you in 100 years. And so I'm really grateful that as a PT, we get the benefit of doing internships, which means many of us rule out what we thought we wanted to be when we grew up. And so for me, I first was a PTA. Initially, I went to a 2-year program to be a PTA. I was inspired by my family. My father had a traumatic brain injury. My mother helped me find a program where I felt like I could give back and perhaps work with people with TBI. And the reason why I really wanted to do that was not necessarily the TBI, but really our experience with the healthcare system itself was not great. And that was probably the hardest experience I've ever been through, the hardest experience on my family. And so it was through that lens that I was looking to do something to improve that. That became my purpose. And so I also didn't think I really wanted to go to college that long. So my mother kind of helped convince me that this 2-year program was something that was perfect for me, which is fun. I literally just finished my PhD a year ago. So I've been in college ever since. But when I first started that and did my first internship with TBI, it was not a good fit for me. It brought a lot of emotion. I realized that was not the best ability for me to make a difference. And so that was a little bit devastating after you finish 2 years of school and realize this is not what you thought it was going to be. But I had an amazing teacher, and her name was Sandy Feather, out of Harcum. She worked at St. Agnes, and in class, she talked about wound care, the holistic approach, how it can make a difference, thinking about all these aspects of the human experience, from the psychosocial to mobility to nutrition and so on. And so I was lucky enough to do an internship there in wound care, and it was a home run. And what I realized is it was through this wound management that you really could make a difference in healthcare at large, because it's almost a low hanging fruit, even though it's so challenging and difficult. It's the one thing you can see, and that as a team we can come together and truly make a difference for that individual. And so it's a weird sequence of how I got to where I was, but once I started in that world, it was the perfect fit for me and it made sense. This is how I can make a difference.
That's brilliant. And if I'm timing this correctly, this was in the early 2000s. It's those experiences and
Yeah, along
that
there.
epiphany.
Mhm.
Uh,
Yeah. Yep.
I got started in wound care in 2011, and so I know kind of what happened in the progression of wound care since then. But I love asking people like yourself what it looked like prior to 2011. So but in the 2000s, I mean, what
Yeah.
did wound care look like? It's come
Oh
along
my
a long
goodness.
way.
It is real. Well, everybody was put in the hydrotherapy tank. Open to air. I remember, rolling people over on the stretcher and, leaving the wound open to air at that point. Everybody had Dakins. Didn't matter about the characteristics of the wound. When it came to topical treatments, there was really no evidence base. It was really all preference of what you were accustomed to using, which still kind of happens today a little bit. But I think the craziest story in retrospect, now remember, I'm a 21-year-old kid at this point, and I'm working in this wound setting and just doing, whatever they told me, because at 21, you assume, all these people are really doing the right thing and they know what they're doing. And I recall one time, one of the physicians had me put this individual's leg in a plastic bag, throw oxygen tubing and some medical tape, and the doctor said, "That's hyperbaric." So that was wound care then. But what I did learn is that people who are healthy, people who are healthier were healable, even with questionable evidence-based practices, right? So people who had good nutrition, mobility, circulation, and so on, we're still going to heal despite some of those practices. And certainly people who were more challenged in all those other areas where the team maybe couldn't or hadn't yet come together to make that big difference, it was much harder to get to healing. So the foundational rules are still the same. The topical stuff is certainly important and can make a difference, but we have to look at that person holistically in order to maximize the benefit of what we do on top of the wound.
Oh, absolutely. And I think that's become much clearer in modern wound care. In 2011, one of the things, again, working post acute like you, was that there was always almost an obsession with medical directors about the wound, the wound, the wound. And our
Yeah.
specialists would go, yes, the wound is the problem, but there's a whole slew of underlying issues that we have to attend to in order to manifest healing in the wound, and
Yeah.
getting people to understand nutrition, even the psychological status of the patient,
Yes.
is important. And so I think we've come a long way, but you're absolutely right. I remember going to nursing homes in 20, between 2011 and 2015, and just having the same conversation over and over again, saying, guys, you can't solve the wound, you have to solve the patient. Right.
Yeah.
And,
I love that.
you
Yeah, I
know,
mean, the wound truly is a window into the overall health of that human being. And so, early on, even with wound rounds in the nursing home, where the nursing home, in that space, you do have a team approach. You do have social service and nurse and therapist and physician. And so you have an ability that we didn't have in that outpatient setting or in acute care. And I think that's one of the things that intrigued me the most. But in the early days, we would do rounds, and you're right, it was all about the wound and what's the topical, and the wound's not progressing, so let's change the topical. But we didn't ask the deeper questions. Does the patient have diabetes, or is their blood glucose stable, and so on? And so I saw that evolve over time, but there are still practitioners who focus solely just on the wound and the topical, and so they're missing healing opportunities for sure.
um, so you finish up at St. Agnes and you start at Genesis as
Yeah.
a director of rehab. Now, I must tell you something, and I told this to Julie in the last podcast. I uh, I committed a crime against you. I
Oh,
stole a handbook. Stole is too strong a word. I borrowed a handbook you had written for Genesis. It was the 300-page manual that you
the
wrote
center.
around. Exactly, exactly. And I had a friend of mine at the then Inglemore Center.
Oh, yes, in Jersey. Yes, I remember
Yep.
that center very well.
Exactly, exactly. So we were servicing the building, and she said, "Oh, we have to make sure we're in line with these procedures." And I said, "Oh, do you have a copy of those procedures?" And she said, "Oh, it's in this book." And I said, "What book?" And so I'd heard of you before, but then I saw the book, and I was like, "Who writes 300 pages on wound care?" I said, "Can I have that?" And she's like, "Yeah, I think that's okay." And so I kind of delved into the wound care mind of Jeanine Maguire circa 2012. And it was an
Oh,
absolutely fantastic magnus opus on post-acute wound care.
I'm so honored by that. And I can't take credit of that alone because the one thing at Genesis, I took from St. Agnes the team approach. And when I came to Genesis at that one center, Quakertown Center in Quakertown, PA, as a director of rehab, I teamed up with the director of nursing at that point. And she and I started wound rounds together in that center. And it grew into 30 some centers in PA and then 60 some centers in PA, New Jersey. And then it took off into something that became a national level for the company. But one of the things that I did was worked with our Skin Integrity Council. So we created a mini PAWSIC, or I should say, PAWSIC is based on the idea of that skin council at Genesis, where we had nurses and dietitians and pharmacists and risk managers working together to really understand what it takes to get to healing for that individual, from all different aspects. And so, thank you for saying that about the center framework. That was definitely an entire team approach, but I'm glad you found it valuable. And I'm thrilled to hear the centers were using it. Even better.
Oh no, absolutely. I think we initially had you had acquired these three centers, so they were independent centers. It became part of Genesis. So it was Inglemoor. There were three in North Jersey, and then I kept running into the same book. And then the folks at the Cinnaminson Center
Yes, yes.
loved it when they would always make reference to it while we were providing services there. So definitely it was something that was used that I saw as an outside vendor, that people referred to and put a lot of trust into.
That's
So
wonderful to hear.
so yeah, it was. You are the director. Genesis is growing. I remember they also did a deal, I think circa 2013, to acquire all those facilities out west, if I remember correctly. And so you're just trying. You become the VP of clinical, and how do you manage? How many nursing homes did you? I think you were up to like 500, 600, some ridiculous number,
We
even
were
more.
at one point 500, and so my responsibility was to oversee skin and wound, and the way I did that again was the skin council. And so it was through working together as a team with our national educators, and again, pharmacy and dietitians, and at that point we had our Genesis physician group. And internally, I created our own internal wound cert prep workshop that we would put all of our nurse practitioners through that had that interest, RNs. Also working internally over time. This happened in the last couple of years. We created a new position in all of our centers called the Skin Health Team Lead. And so that position is, I didn't want the focus on just the wound. So I wanted that team lead to pull the team together to understand the role of the physician, the provider, the nurse practitioner, the PT, the dietitian, the family, the patient as really driving the bus, and us helping them and the family make the right decisions based on what was possible, and making sure they understood what does it really take to get to healing, and how long could it possibly take, and is this the way in which you are ready to live your life. The certain measures that for some people in their 90s might be a little bit more than they bargained for, if it's the strict diet and exercise protocols and so on. So, really making sure that we care planned with the patient, for the patient, and the family. And so, the way I pulled that off was the way the Skin Integrity Practice Council pulled it up off. It was together as a team, working with every facility and empowering them with the tools. So things like that framework and other protocols and guidelines support. And I will say we did institute some technology in about 200 of the centers as well. I am a huge supporter and belief in transparency of all things medical, and especially wounds. And so having wounds images, photography done the right way with the right apps, that's privacy, HIPAA compliant, and so on, is a game changer to really making sure we have the right diagnosis, the right plan of care, and the team truly engaged. So, um, there was a lot of different things that I did, a lot of great people I got to work with, and also bridging the gaps through technology to really try to extend a higher level of care to all of those centers.
No, it's brilliant. As a data guy, I mean, you know, how do you, so you have to measure and compare facilities, right? Across multiple states, across multiple star ratings, across multiple measures of what they come in with, right? So you may have one center that has a nosocomial rate of 5%, right? And another center that has a nosocomial rate of, let's say, 40%, right? And saying, okay, how do we compare facilities? Like, how did you think about managing, close to 500 homes and comparing all these different practices and nosocomiality? How did you kind of work through that with your team to make sure that you could identify facilities that were underperforming, facilities that were performing well, and everything in between?
Yeah. So if you talk to different nursing home operators, they will probably have similar responses. Everybody, of course, has variation, but the reality is CMS is only really tracking. When you say nosocomio, you're talking about the pressure injury rates, I'm assuming, not all wounds, right? So, CMS, Medicare is really focused on pressure injury rates, on that MDS, and there's a delay in getting that data from CMS. It's not real time, of course, and you don't actually know if that patient's wound on CMS or the QM is the same pressure injury from 6 months ago, or they closed and reopened another. You don't even know the body part it's on. So the majority of nursing home organizations are all collecting their data internally. And if they're using any type of tech, then that tech should be collecting it too. And so what my recommendation is for anybody is you need your own incident rates, prevalence rates. You need your own real-time wound log of every single wound. And the literature out there says that there are about 30% of your wounds on any wound log are going to be atypical. So without having, again, the images and getting a certified wound specialist to review those images to make sure you have that right, your pressure injury rate will be skewed, because I guarantee that some of the wounds that are getting listed on that MDS are not pressure. And so, when we look at rates, or when I looked at the rates at that time, a couple of things. If the rates were really high or really, really low for that matter, I'd want to see the real time wound log and photos. If there was no photos, I want to get in the center and see the actual wounds, because we need to make sure the wound diagnosis is accurate. That's first. The second thing is thinking about pressure injuries a little bit differently. And this is one of the pieces of culture that I tried to push and I still believe in strongly. Stage 1 and 2, we know can happen in just a few hours, right? And a stage 1 or 2, if it happens in just a few hours and your CNA can detect it, and that CNA might have 10 other patients. If they can find that stage 1 or 2 in 1 or 2 hours, that's amazing care that they recognized that it's a potential stage 1 or 2, and that they reported, and that the nurse responded in the busy day of everything else going on. That needs to actually be acknowledged, and we need to celebrate that behavior, not because we want stage 1 and 2s, but because they happen, and we don't want people afraid to report them. So that's one of the issues. So there's a lot of organizations that, when the pressure injury occurs, it's a very negative enforcement that can occur. People are afraid to report, and then you have hiding and so on. The problem with that is you end up with more threes and fours. We want everybody to report at stage 1 and 2, because that's still healable, even in the most vulnerable population, most of the time, unless they're actively dying, right? So that's a bit of a culture shift. If we can get people to report stage 1 and 2s and get those interventions in right away, that's a good thing. Because if we don't find pressure injuries until a 3 or 4, you and I both know how hard that is to heal, how long it takes, and that healing pathway is not a fun pathway for that patient either. So there's a lot that they have to do and change their life, the way they eat, the way they move, their medications, their quality of life. Maybe they're embarrassed about having these dressings, or the drainage, or the odor, and so on, and just going through significant dressing changes. And so once we get to that 3 or 4, if you have a brand new in-house acquired at a 3 or a 4, that's the problem. Why didn't we find it at a 1 or 2? Who did the skin check the shift before, the day before? Those are the kind of questions that you really want to investigate. So that's the shift that needs to happen if it hasn't happened already in all nursing homes. We want to encourage early reporting of 1 and 2. And when we have a 3 or 4, I highly recommend that the nursing homes use the critical element pathway by CMS, FTAG 686, and the team, not one person, it's not paper compliancy, but the team actually does that investigation and finds out who's looking at skin, who's reporting it, who's doing the interventions. Are your bed surfaces viable? What kind of mobility are we doing? What kind of restorative programs do we have going on? What's the nutritional program? And so on. And so it goes back to the team approach again and holding everybody accountable to early reporting.
No, you're absolutely right. I'll second everything you've said. You know, we sat on the other side as consultants, and
Mhm.
so what we found, and all the great mobile groups do this. They understand that you are not a savior coming into a building. That's that's
Mhm.
not what it is. You are a leader who helps to assemble a team and keep that team motivated and in line to identify good behaviors, right?
Yeah.
And then working with management at that facility to further accentuate those good behaviors. So it's interesting hearing from you as on the operator side, because that's what we found. I mean, at our apex, we were at about 400 or 500 nursing homes, and the nursing homes that were successful were the ones that were willing to engage in that teamwork. And
Yes.
again, transparency. We,
Yeah.
it's not bad to identify a pressure ulcer. The alternative is far worse, and early is better than late. It's just that simple. But you're right. There is a massive problem with hiding of wounds. I mean, many times we would get clients who would bring us in post tag in the correction period.
Mhm.
We'd come in and we're like, listen, let's get everything above board. Let's figure out what we have here because then we can come up with a game plan because the tag usually is an indicator of far greater problems. Right?
Agreed. Yeah.
It's not like there's one in the facility. All right, like this is just you might have gotten unlucky, but it's there's something going on, and so that teamwork element is just massive. And I think there's been a lot of talk of AI and technology, and to me at least,
Mhm.
during my 12 years in post-acute wound care, it's a people game, right?
Mhm.
It's engaging, getting people to be honest, transparent, and working together with good science and having that repetition on a daily basis. Technology is not going to save you. It can help you, but it won't save you. So
Yeah.
I second everything you've said, and we saw it on our side. It was very
Yeah.
obvious when these failures occurred. I have two questions that I've actually, now that we're talking about this, that during my career in post acute, always confused. One was we would go to facilities and there would be nurses aides or DONs that wanted to stage a wound as a pressure ulcer, even though we were
Mhm.
telling them it's an MASD. Or so, and they'd
Mhm.
actually fight with us. And I used to think to myself, why would you want a pressure ulcer when we have clear clinical indications that it's not? So that's question one. And then
Mhm.
question two, one of the big failure points that we saw was on admission, that transition from the hospital into the home where people were not identifying these cases quick enough or just totally
Mhm.
missing them. So,
Mhm.
one, why would people want to stage an MASD as a pressure ulcer and literally fight with a CWS? And number two, how do we deal with that failure at point of entry?
Yeah. Okay. Really good points and questions. The first thing I'll say about it is, in my experience in nursing homes, this isn't a Genesis thing. This is a nursing home thing. A lot of things that are done because of lack of knowledge. When you look at the turnover rates of staff in nursing homes, it's unbelievable. So it's for me teaching wound basics for the last 20 years. It was like Groundhog Day every week. So it was just wash and repeat with new staff. So there's a lot of lack of knowledge, and that's not to the fault of the nurses, or I'm talking about lack of knowledge from people who claim to be wound providers coming to our centers and they're not wound specialists. And so, they've led people astray. We've had citations because of those groups. And so part of it is lack of knowledge and part of it is fear based. And so the lack of knowledge is a real thing because in academia, none of us, whether therapists or nurses or physicians, wound care is not a standard of care that most of us get in school. There's not like a track for wound management. So we come out of school and go into practice, and we have regulations in skilled nursing, FTAG 686, that we're held accountable to, but most of us are not even educated to understand our role in that guidance. So that's one thing. But then when you come into the nursing home, you have these citations. Your average G level citation is $15,000, not at Genesis. That's a whole average citation across the country. So you have these citations. Oftentimes, nurses are called out by name, or so are providers in that actual citation. So there really is a palpable level of fear. Have you ever felt that in a center when they were in survey? That palpable level of fear of everybody in that facility. So there's a lot of fear based actions on behalf of a lot of people in that situation. The other thing is, in centers where perhaps they had gotten in trouble because they misdiagnosed. It is a diagnosis, right? They misdiagnosed and they failed to call it pressure when it was indeed perhaps pressure. And there was some trouble around that. There was education, and now everything's pressure. So the pendulum swung. And so now they're so afraid it's on the sacrum, it must be pressure. And so that's likely the reason why they're pushing back a little. But the other reason they might be pushing back is if a provider's in there and I believe it's this wound type, even though you've already called it that. The reality is we have to make sure that the documentation by the physician, the medical director, the attending, and the physical therapy documentation, the dietitian's documentation, the nurse's documentation, the orders, the care plan, all match. So they all might say pressure, and now your provider is saying, no, no, it's MASD. So it involves a team meeting. All those brains have to come together, come to consensus. This is an error in the diagnosis based on this description by the certified wound specialist. This is actually MASD. We need to make a change and a note to justify that change. So it could be fear based. It could be like, oh my gosh, how are we going to even handle this change of wound type diagnosis? So it's not an easy answer. But at the end of the day, we have to make sure that the diagnosis is indeed correct, or else the care plan is not going to be correct. The healing pathway is not going to be correct, right? And so we're still going to end up in a sticky wicket with regulation, and worse, the patient's not going to get the right treatment. So it still has to be done, but that is very frustrating. The second thing is on the new admissions, the admission diagnosis in any skilled nursing, any nursing home is very lengthy. And remember, not all of these nurses know, they're not all wound specialists. And so that full body skin check, it says, according to reg, it has to be done on admission, but it doesn't have a timeline. Now, I always recommend, because we know a wound, a pressure injury can happen in 1 or 2 hours. In my mind, you need to do that skin check like immediately on admission. It needs to be the priority as you're making sure that they are, stable enough to go through that skin check. That needs to be sort of step one. And if they miss that skin check and they don't find that wound, let's say it is a pressure, for 8 hours or 10 hours the next shift, how can you say it was present on admission? How can you say that? If a pressure injury can start in 1 or 2 hours and you're looking at a stage 2, how can you say it was not there or was there? You really can't. I mean, unless the hospital records actually say that they had that wound, but you and I both know plenty of people come to skilled nursing without any evidence and documentation of any wound whatsoever, and we find them on admission. So why we're missing that, I think it's staffing. I think it's, potential staffing that aren't trained in doing the skin check. Maybe it's not having the support because skin checks are not easy. And certainly for that patient, not always comfortable. So we have to make sure the patient understands why we're doing this. They just came to us from a horrible scenario that left them in the hospital for days, and now they're in a brand new environment and we're taking off their clothes and doing a skin check. So sometimes we need to give the patient a little time before we do that as well.
No, that's brilliant. That makes total sense. I feel like you're taking me to school. Uh, no, it's fascinating because the perspective from the operator and kind of these you see these things, these same problems. Doesn't matter on the geography.
Yeah.
I've had the pleasure of visiting nursing homes in, gosh, probably 30 states, and it's the same issues. It's not exactly the same, but it just rhymes over and over and over again. So I
It
think what you
really
just
is.
said will be helpful to people.
Yeah, I mean, truly, as I said earlier, and I know you agree with this, an individual does not develop pressure injuries when they're happy, healthy, and mobile. They just don't. So it's individuals that are really having difficulty in any system of their body, including psychosocial, that are going to be those that break down. And once you break down once, your risk of breaking down in other areas is tenfold. So when an individual is breaking down from pressure, it's a sign, it's a window into their overall health, but you can transpose that idea to a nursing home. If you have a nursing home that has a lot of breakdown from pressure, that is a window into their overall health of their systems, their staffing, their knowledge, and so forth. So, wounds are an easy way to look at how is this center performing overall. Because, as you said, if they have a wound issue, it's not just a wound issue. They have other systems that have have opportunity to improve.
Yeah, absolutely. We've got about 25 minutes left, so I want to really talk to you about something that I find very fascinating in the work you're doing, which is we've talked about post acute wound care. Love to talk to you about two things: end of life wounds and PAWSIC. End of life has been a big discussion point. I'd love to get your insights about that. And then if we can spend the last part talking about your work with PAWSIC, which I think is absolutely brilliant, it would be an absolute pleasure.
Yeah, thank you for that. I'd like to start with PAWSIC, and then that will explain the end of life, if that's okay. So, so PAWSIC is the Post-Acute Wound and Skin Integrity Council. PAWSIC was an idea that Sarah Holden Mount, she's the president-elect, she and I chatted about for years. For years, we met each other at, I think, NPIP at one point, but we met each other at different conferences. And we would just talk about the fact that, there's not an organization to support us in post acute care for all wound types, all disciplines, that's really about a patient centered team approach, but through the nuance, through the lens of all the regulations, all the litigation, all the things that are special to that space. And so, as we continued to talk about this, I think Julie Radovi and I were at SAWC on a bench and on a napkin. We kind of drew out our vision of what we thought this would look like. And, we roped in Diane Krasner, who started other organizations, and she really gave us a lot of guidance. Mary Lee Grosso, who's our secretary, who really was one of my mentors at Genesis with running committees and organizing and so forth. So we got together, found 15 other purpose driven, passion driven individuals in wound care that were all of us, willing to basically do more work with no pay over the last 3 years to create PulseIC. And last October, we finally received our tax status of a 501 C6. And so that was our original coming out. HMP has really been our ability. They supported us from day one in launching. And now you'll see we have so many sponsors that are helping us continue to grow. And so, between our sponsors and our members, we wouldn't be doing what we're doing now. So super grateful. But the whole idea of PulseIC is everything I've been talking about today. It's really to be a resource, an advocate for all stakeholders in post acute care. So, first and foremost, our patients, to give patient voice to plan of care, to make sure that we are addressing their needs and provide education to patients and their families, our nursing assistants, but also a resource and advocate for our colleagues. We talked earlier today about rarely are we academically prepared, but boy, are we held to a very high level when it comes to litigation and regulation. And there really is no standards of care. So, how can we support our colleagues in this really hard work of wound management? So, we want to be there for them as well. And really, at the end of the day, what's most important to us? is collaboration. So the one thing I believe is we are better together. So since we started this, we have had a lot of other organizations endorse our work and work with us, and that is really making us stronger and what we're able to provide back much better as well. So that's just a little bit about the beginning of PAWSIC. We've been doing a lot of work, and you mentioned skin failure. So should we tackle a little
Yeah,
bit of that right now?
absolutely. Yes, please.
All right, so skin failure is just one thing that PAWSIC does. Skin failure became an issue for us when we launched in October, when CMS came out and said in the regulation that if a wound is from skin change at life's end, skin failure, and it's not primarily caused by pressure, it should not be coded as pressure. So that's important. That's important to you as a provider, your provider groups, right? It's important to the teams. It's important for patients and families to understand that this is not a pressure injury, but the result of organ failure and so on, as an example. So that's all really important. However, there's no code. There's no code for skin failure or skin change at life's end. So as a provider, how do they code this? As a researcher, how do we research it? How do we even find the data on it? And so we recognize that this is a problem specifically for post acute care. So that's the reason why we first ventured into that area to start to address it, and then learned rather quickly this is not a post acute care thing. It has ripple effects that affects that patient regardless of the setting that they are in. This is a problem for acute and across every single setting, but not only in our country. It's a global issue. So it's a human issue, right? And so because of that awareness, again, the idea of better together, working with collaborating organizations, looking at the work that's been done before us, standing on the shoulders of people that are great and that have published on this to really pull together to get an ICD-10 code. So that's the idea. We want to get the code. The code will then allow for the research to occur. The code will allow for coding guidelines. The code will allow for guidelines on care and communication. So that's why we took that on. Where we're at right now is we just presented an international roundtable where we had some excellent speakers talk about their viewpoint, their experience. Our collaborating organization from the beginning has been the American Academy of Dermatology Association. They were recommended to us by the ICD-10 committee because they are not only, obviously excellent with the integumentary system, but they're also expert coders. So they have been our collaborating organization partnering with us since the beginning of this almost. And now we have more than 11 international and national endorsing organizations, as well as many, many individuals that have signed on. So that's just a little bit about that work, and there's still a lot to be done, but that is just one area, one piece of what PAWSIC is doing. Certainly, we're taking on a lot of other issues that are important to all of our stakeholders as well.
That's fascinating and necessary work. At Open Wound Research, we look at sort of the global wound care market, and we look
Yeah.
not only at clinical research but also market research. And end of life wounds is an interesting thing. As you say, there isn't a code, right? And so you
Yeah.
have, I'm going to nerd out here for a second, if the audience and you will permit me, but you have this latent variable that is lurking in the background that you have to look for, right? And so we're actually doing some research right now where we have a big database of pressure ulcers. And so we asked this question, could we identify end of life wounds using statistical methods and seek out this latent variable? And so the team and I sat and we nerded out on what are called cumulative distribution functions of near death, right? And so if the risk of death is constant, right, you would expect like this 45-degree slope of the people you've observed in terms of the time to death, right? So if the risk is
Mhm.
constant, you would see like a 45-degree, right, to death. That's what you would expect if the risk remains constant. But if the risk
Mhm.
varies, at various points, then what you see is an inflection point in the slope over time. And there may be one, two, three, four inflection points. And what that statistically suggests is that there are subpopulations of death cohorts that are occurring. So you might say, for example, there are people that are naturally dying, right? And then there are people that are unnaturally dying. And then within the unnaturally dying, there are certain subpopulations. And so when we started looking at that, we said, wait a minute, we've got this concept of end of life in the literature. We're observing this cumulative distribution function with a non one to one, as a non constant slope of risk. There are subpopulations here of death that are occurring, which implies there's a latent variable occurring, which fits into the science of end of life wounds. And it's been a very exciting piece of study for us, and one that is driven. Most of the research around this has, of course, been driven on the clinical, but it's been super interesting working with a data science team, looking at it empirically.
Yes,
you know,
and that's exactly what we need. We need the research, we need the science behind it. And, I think the ICD code is going to help to identify and pull out those wounds that we believe are that, to determine, what really is going on. But I love that research. I can't wait to see more of it.
yeah, no, we're super excited, and it's something that I think in the post-acute world there is a lot of doctrine that exists, and heterodoxy, and some of it is based in experience and science, and some of it is not. And
Yeah.
so I think we have to have an honest conversation, because not only does it impact the patient, right? And that's where our hearth should be, right? Our hearthstone,
Yes.
our hearth side should be the patient. But we are also impacting institutions that care for these patients. And
Yes.
certainly we want to hold accountable those organizations that are failing through bad management, mismanagement, whatever. But what we don't want to do is to punish organizations who are trying to do the right thing, are doing the right thing, and what is observed is a phenomenon that they have little or no control over. I don't think that's good for anyone.
Yeah, that was well said, and I think that's the concern, over some that are concerned about having a code. Although, again, CMS has acknowledged the existence of this for decades, and so they don't want it in the pressure injury, and it should be documented, but we just don't have the code. The individuals that are concerned about the code, I think, are concerned that people will code things as skin failure that are indeed just pressure. And, I share that concern too. I think we all do as clinicians, because we see so much misdiagnosis today of all wound types. That's where I think we need the imaging. That's where I think we need the codes. We need the transparency in order to research and understand all of these wound types. But further, labeling something as skin failure or skin changes at life's end does not excuse us from doing the right risk evaluation and the right interventions. They still need to be fully in place. So I go back, if you're in a nursing home, regardless of what country you were in, you can still lean on different tools. The CMP is a great tool that you can lean on to make sure that the interventions are all right. But Zweli, to your point, I think about some of the patients I've seen, at the true end of life in organ failure, where they do develop some skin breakdown despite the appropriate redistribution surface and skin care and other interventions. And I think how much the family's already experiencing during that time. And wounds are a visible upsetting phenomena. And to also feel like, wow, and now my mom has this bed sore, when it's not that at all. It's not lack of intervention. It's not lack of, turning or lack of bed surface, but it's part of the organ failure. It's part of the dying process. To have that conversation in a compassionate way is really important. And it's important for our patient. So we provide comfort care appropriately. And it's important for that family so they can psychologically, understand that and not feel more upset over a very upsetting time of their life already.
And that's absolutely true. And I think also another risk not only for nursing homes, but for wound care providers, has been the rise of pressure ulcer litigation. You know,
Yes.
um, we both. You're still a Pennsylvanian. I'm a ex-Pennsylvanian, but in Philadelphia County. Again, I nerd out and read these things because I find it fascinating. The litigation's through the roof, and people are presenting unscientific notions in order to make a lot of money. In many cases, it might be that people have messed up, absolutely. But in many
Yes.
cases, there's a distinct misunderstanding of the science and a misunderstanding of the mechanism of the body at the end of life. And I think that your organization, what you're doing, and the further research into this can give a truer picture of what is actually happening versus what we think is happening, which I think sometimes those two things are very far apart.
Well said. Yeah, absolutely. And I think it all goes back to two main themes of this, conversation today. Transparency. We need transparency. And, we need imaging. We need the second theme, we need the team approach. So, in my opinion, all the skin and wound issues, if I had my way, we'd be taking photos of them all. Again, HIPAA compliant, but then bringing in the team and somebody who is wound certified to review that entire case, not just the photo of the wound, but the photo and wound in context to the patient's story to start really guiding plan of care that is appropriate for that individual.
No, I think it's not a new idea. It's
Right.
not, it's an old idea that works. It just works,
Yes.
and I think if people are to take any lessons from the podcast today, it's that teamwork. You know, I think the benefit of teamwork, and we used to sit in our management team and talk about this, but this is what's crazy. An individual by themselves who is ignorant. But if you take five ignorant people, they start canceling out their aggregate ignorance.
True.
Right?
Interesting.
Exactly right. Because if you don't know what you're doing and you're by yourself, you have no feedback loop, right?
That's true.
But if there's
Yeah.
five people who don't know what they're doing, but people are bringing different skills, different mindsets, attention,
Yeah.
you're mitigating the ignorance to a certain level. And then to your point, bringing in direction and experience, whether it's internal to the organization through a training program or external by bringing in people from outside. Now you're mitigating ignorance that is incredibly harmful, and there are no messiahs in wound care. Right? And I think
Yeah.
that a lot of the times I saw this when we would come into buildings, how are you going to save us? Right?
Oh, oh, yes. Well, aren't you the wound program now? Don't we'll just wait for the 1 hour visit a week and call it a day. Yeah, that's a problem.
Yeah, absolutely, absolutely. And I just think your point is right on point. There is no messianic wound care. There's team wound care, and you can have a great leader. But at the end of the day, once that person leaves the building, what occurs?
Yes,
I just,
absolutely.
again, I love the work you're doing. I think that, especially with the growth of the geriatric population, the cost
Yeah,
attached to that population, it's only going to get worse. It's not going to get better.
that's right. Yeah, so we have to do better. We as in the entire healthcare community have to learn how to do better.
Absolutely. So I had one question when I was reviewing your resume that I just thought was fascinating. Your whole resume is fascinating. Let's stipulate to that. But this just stood out because I was like, huh? What does this mean? You are a fellow of the Philadelphia
Yeah.
College of Physicians. What's that
Yeah.
about?
So I was nominated by the Pennsylvania Geriatric Society that I sit on. And so they nominated me for the work that I've done in wound care and the work with different organizations and for starting PAWSIC. So that was certainly a big honor. That was less than a year ago. So I'm still learning exactly what that means and the responsibilities that go along with that. But it was quite an honor to get to be among that group of people. And I thought it was just for physicians, but it's for those with a doctorate as well as practicing physicians.
Oh, that's brilliant. That's prestigious in the Philadelphia area. That's well known, and congratulations to you. And I think they've gained themselves a very valuable fellow, and I think they
Thank
obviously
you.
realize
I
that.
appreciate that. I'm just hoping I can get them to start talking about wound care.
And so we've got about, let's see, 4 minutes left. Two questions to kind of close this out. One is SAWC is upcoming in just over a month. I know PAWSIC is rocking and rolling at SAWC. So what do you guys have going? What are you guys doing? And how can people engage?
Yeah, thank you for that. So we'll have a booth again. So thanks to HMP. So please come and meet our members at the booth. I'm not sure if we're going to do something more than that. So more to come, but we will be at spring as well, and we will be doing a little bit more at spring this year than we are at fall. So thank you for that mention, and hopefully I'll see you all there.
Brilliant. Are they doing? I know at SOC there's a lot of focus on diabetic wounds, a lot of focus on you know the globe of wounds. Is there a pressure ulcer track or post acute track this year?
So there's not a track, but there are some presentations specific to post-acute care, or that would be appropriate for post-acute care. And I think what's important is a lot of the mobile wound groups may not sign up themselves under post-acute care, but these presentations are absolutely applicable to any mobile wound physician group that is going into patients' homes or nursing homes, ALF, and so on. So definitely look for those levels of presentations. There are some presentations. These are not PAWSIC, these are SAWC, but there are presentations on social determinants that I think are vital to our practice, particularly when we're seeing patients at home. So there are some new and exciting presentations that I think would be applicable for anybody who's practicing in that space.
Oh, brilliant. I think we'll put some of that stuff in the show notes. I know registration is still ongoing, and I know a lot of people are going. And we'll put some things in the show notes to help guide people. My wonderful assistant Danette is hopefully listening at this time, but we'll put some stuff in there for people to register that. So, final question in this hour of I hope it's not torment but elucidation is if you had infinite time and resources and you could solve one problem in wound care, what would it be?
Okay, this is going to solve more than wound care. This is the idea of seeking whole. What I mean by that is see beyond the wound, okay? And if I had my magic wand, it would be that we treat people holistically. And I know that idea is not new at all, but starting with the patient and starting to spend the time to figure out what matters most to that individual. Because what I still hear, and you probably do too, is amongst all of us in wound management, one of the things that we often struggle with are what we label as the non-compliant patient. I'd like to flip that upside down and say that there's really not non-compliant patients. There might be non-compliant practitioners and team members because we're failing to understand what matters most to that person, and then working with them, their level of health literacy, to explain to them what that wound type truly is and what it takes for them as a human being to get to healing, so they understand and we remove barriers so they can adhere with that plan of care. And so if I had a magic wand, it would be that we all begin to think about the patient first, give the patient that voice, and really understand what matters most to them when we engage. That's it. And I think that would actually make a difference for a lot of different issues that people are challenged with, everything from a wound to a TBI and in between.
That's brilliant. Thank you for that. And I appreciate that
Thank you.
answer. That's brilliant. Well, that brings a close to our time. This has been a great talk. I hope people got a lot of value from your insight, which is, invaluable. And I think we should start charging people for these insights because they're just fantastic. But we won't. But I think this is just fantastic. And I appreciate your time. I appreciate your insight. And I appreciate your ongoing work and the work of your team in looking after our elders. So thank you for that.
Thank you, Emily. It was a privilege. It was an honor for me to get to be on here with you today. Thank you for your work, and I look forward to working and collaborating with you in the future as well. Thank you, everybody.
Thank you.